Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 470 of our pharmacotherapy series, which majors in adult hematologic malignancies. The next case reads, PPA, a 64-year-old male, presents with complaints of swollen lymph nodes and occasional fevers and night sweats during the past month. Physical examination reveals marked cervical, supraclavicular, and inguinal lymphadenopathy. Laboratory values are normal with the exception of a mild anemia and an elevated lactate dehydrogenase. Excisional biopsy of a supraclavicular lymph node confirms a diagnosis of diffuse large B-cell lymphoma, abbreviated as DLBCL. Flow cytometry is positive for CD10, CD19, and CD20 surface markers. He does not have any identifiable extranodal disease. So my first question to you reads, is PPA's disease considered curable? Diffuse large B-cell lymphoma represents about 25% to 30% of all cases of non-Hodgkin lymphoma and is the most common type of lymphoma. Incidence of diffuse large B-cell lymphoma increases with age, with the median age at diagnosis occurring in the sixth decade of life. Anticipated 5-year survival rates range from 21% to 76%, depending on various prognostic indicators. Adverse indicators include age older than 60 years, elevated lactate dehydrogenase, multiple extranodal sites, advanced clinical stage, and poor performance status. Although the potential for relapse is relatively high given his numerous adverse indicators, the goal of therapy for PPA is, nonetheless, curative. My next question to you reads, given this information, what is generally considered the standard of care for PPA? A combination of chemotherapy and immunotherapy with or without radiation is the foundation of therapy for diffuse large B-cell lymphoma. The cyclophosphamide, doxorubicin, vincristine, and prednisone, abbreviated as CHOP, protocol has been the prevailing chemotherapy backbone in diffuse large B-cell lymphoma for decades, owing to its activity, tolerability, and simplicity in comparison with previously utilized regimens. The inclusion of rituximab, a CD20-targeted monoclonal antibody, with cyclophosphamide, doxorubicin, vincristine, and prednisone therapy, abbreviated as R-CHOP, increases survival by approximately 10 to 15%, with only a nominal increase in adverse effects. Likewise, Immunotherapy with rituximab is integrated into virtually all therapy for diffuse large B-cell lymphoma. For patients with stage 1 or 2 disease, a treatment course consists of 3 cycles of rituximab cyclophosphamide, doxorubicin, vincristine, and prednisone followed by involved field radiation. If relative contraindications or aversions to radiotherapy are present, adequate results can typically be obtained by omitting radiation and extending chemotherapy duration. The large size and/or extent of disease limit the utility of radiation in patients with advanced disease, stage 3 or 4 or bulky tumors. As such, administration of rituximab cyclophosphamide, doxorubicin, vincristine, and prednisone for a total of 6 to 8 cycles is the predominant practice in this setting. Chemotherapy with cyclophosphamide, doxorubicin, vincristine, and prednisone plus rituximab, because his lymphoma is CD20 positive, for 6 to 8 cycles would be ideal for PPA. The addition of radiation treatment is not beneficial in this setting because PPA has stage 3 disease. During completion of pre-treatment assessment, PPA is found to have a past medical history significant for cardiac disease. His ejection fraction is revealed to be 45% following an echocardiogram. Final cytogenetic analysis reveals his lymphoma is positive for CMYC and BCL2. So my question to you is, do any of these findings change the therapeutic approach for PPA? If so, how? Notwithstanding its proven reliability, therapy with rituximab cyclophosphamide, doxorubicin, vincristine, and prednisone is not applicable to all patients with diffuse large B-cell lymphoma. Anthracyclines, such as doxorubicin, are a cornerstone of numerous lymphoma regimens. This presents a significant clinical challenge for patients with underlying cardiovascular disease. Replacing the doxorubicin in cyclophosphamide, doxorubicin, vincristine, and prednisone with either liposomal doxorubicin or mitoxantrone may be reasonable options to limit cardiovascular toxicity, although efficacy is compromised. The etoposide phosphate prednisone oncovan cyclophosphamide hydroxydaunomycin regimen has substantial efficacy in diffuse large B-cell lymphoma and employs infusional doxorubicin, which is thought to minimize cardiac effects. If the anthracyclines and related compounds must be avoided entirely, the CEPP regimen, that is cyclophosphamide, etoposide, prednisone, procarbazine, is feasible. Alternatively, etoposide or gemcitabine serves as acceptable replacements for doxorubicin in the cyclophosphamide, doxorubicin, vincristine, and prednisone regimen. Treatment of very frail or elderly patients with diffuse large B-cell lymphoma represents a similar challenge to those with cardiac disease. Maintaining dose intensity is ideal given the curative intent of therapy. However, this is not attainable for all patients and use of reduced intensity therapy may be required. The presence of CMYC and BCL2 typically appears in non-Hodgkin lymphoma with features intermediate between diffuse large B-cell lymphoma and Burkitt lymphoma. These findings, often referred to as double-hit lymphomas, are indicative of a poorer prognosis and reduced responsiveness to conventional therapy. Escalation from cyclophosphamide, doxorubicin, vincristine, and prednisone to etoposide phosphate prednisone oncovan cyclophosphamide hydroxydaunomycin, a protocol with known activity in Burkitt lymphoma, appears to increase response rates with acceptable tolerability in this subset of diffuse large B-cell lymphoma patients. A change from rituximab cyclophosphamide, doxorubicin, vincristine, and prednisone to etoposide phosphate prednisone oncovan cyclophosphamide hydroxydownomycin plus rituximab might be advantageous for PPA because this treatment is potentially superior given his cytogenetic abnormalities and may be associated with reduced cardiac complications. 4 years after completing therapy, PPA experiences a relapse of disease. In addition to his lymphoma recurrence, his physical condition has significantly deteriorated since his first therapy due to worsening of comorbid disease, unrelated to his cancer. So my question to you reads: what is the goal of additional therapy for PPA now that his disease has recurred? Eligibility for bone marrow transplant is a critical component in decision-making for the management of relapsed or refractory disease. The aim of therapy for appropriate candidates is administration of aggressive chemotherapy to induce maximal response followed promptly by autologous transplant. Comparatively, the approach to patients that are not transplant appropriate, fail to respond to therapy, or relapse following transplant is largely palliative. Numerous intensive regimens have been successfully used to induce remission prior to autologous transplant. No option has proven superior to another, and all are associated with significant hematologic and non-hematologic toxicity. Although efficacy data are limited, rituximab is frequently included into these salvage regimens. Treatment with less intensive therapy such as gemcitabine plus oxaliplatin, abbreviated as GemOx, or bendamustine and rituximab is ideal for patients not pursuing stem cell transplant. Low doses of single-agent chemotherapy may be a useful approach to palliate symptoms caused by large masses. Now at age 68 and in suboptimal physical condition, PPA is not likely a candidate for aggressive salvage therapy followed by bone marrow transplant. A reduced-intensity treatment such as bendamustine and rituximab may be beneficial at controlling disease, though the aim of therapy in this setting would be palliative. We will now look at other aggressive, non-Hodgkin lymphoma subtypes. Burkitt lymphoma is a quintessential aggressive malignancy that demonstrates an exceptionally rapid proliferation rate. Urgent therapy is crucial and must be more vigorous than conventional diffuse large B-cell lymphoma protocols. Active regimens include the McGrath protocol, hypercyclophosphamide, vincristine sulfate, adriamycin abbreviated as CVAD, or various cancer and leukemia group B, abbreviated as CALB, protocols. Although many of these regimens were developed in the pre-rituximab era, the monoclonal antibody is generally included given the limited impact on toxicity and evidence suggesting improved responses. The etoposide phosphate prednisone oncovan cyclophosphamide hydroxydownomycin regimen is a viable therapeutic option with improved tolerability and comparative efficacy to other commonly used regimens. Given the predilection of the disease to involve the CNS, prophylaxis with either intrathecal chemotherapy or high-dose methotrexate and cytarabine is an imperative component to Burkitt lymphoma treatment. While treatment-related complications can be severe, durable remission is attained in 60% to 90% of pediatric and young adult cases. This favorable prognosis dissipates when the disease occurs in older populations. Mantle cell lymphoma harbors the incurable nature of indolent lymphoma while displaying the capability for rapid proliferation of aggressive disease. Therapy for the disease reflects this dual nature because therapy ranges from low-intensity indolent regimens to high-intensity aggressive regimens. While there is no current standard of care, conventional practice is to administer intensive regimens such as hypercyclophosphamide, vincristine sulfate, adriamycin with rituximab to young and medically fit patients based on the perceived advantage in disease response. Protocols such as bendamustine and rituximab or rituximab etoposide phosphate prednisone oncovan cyclophosphamide hydroxydownomycin are ideal for elderly patients or those with significant comorbid disease. Various combinations of antineoplastics or single-agent therapy with ibrutinib B, a Bruton tyrosine K inhibitor, have shown efficacy in the relapsed or refractory setting. Autologous or allogeneic bone marrow transplant may be considered for carefully selected individuals. We will now briefly look at indolent lymphoma. In contrast to the aggressive lymphomas, indolent varieties are subject to slow growth and typically do not require treatment until the patient is symptomatic. Although numerous effective treatments are available, indolent lymphomas are frequently incurable and prone to recurrent relapses. Treatment is aimed at prolonging survival and palliating symptoms by reducing disease burden until the malignancy either becomes resistant to therapy and/or transforms to a more aggressive lymphoma. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 471.